Pleasure today to have Dr. Kassem from an advanced cardiac imaging fellow from Mount Sinai West to present a great case. And also we have a great panel with Dr. Beasley, Professor of Medicine and Pathology, Molecular and Cell-Based Medicine. Thank you for coming, Dr. Beasley. Thank you very much. We have Dr. Contreras, who has been a frequent visitor in this conference, Associate Professor and Heart Failure and Transplant. Dr. Cooper, Associate Professor and Director of Cardiovascular Imaging in Mount Sinai West. Thank you for coming, Nina. And also Dr. Rabinovich, Associate Professor, Non-Invasive Cardiology and soon to be Director of the Echo Lab in Mount Sinai West. We will miss you. We'll miss you.
Not going too far.
He's not going.
This
He's not
where we
going.
go.
I'm busy.
And the moderator will be Dr. Hadley, famous guy always here. We have a great case, and I want to commend Dr. Hadley because it's a very interesting and very different case than the ones that were presented before. Very educational, and he spent a lot of time trying to arrange this with Dr. Kassem to make it happen. Thank you very much, Dr. Kassem.
Thank you, Dr. Larakis. So our case today is a 38-year-old male with a past medical history of non-ischemic cardiomyopathy presumed to be alcohol-induced. The patient had orthotopic heart transplantation on October 2022 after a bridge with BIVAD. So he presented to our ED with a chief complaint of palpitations and shortness of breath. He reported palpitations, waking him up from sleep twice on the day of presentation, and he also reported shortness of breath since 2 days prior to presentation with some night flight. Physical exam was unremarkable except for tachycardia of the pulse of 113. Otherwise, vital signs were fine. So I just want to point out that his BMI is a bit elevated with a BSA of 2.4. This is the EKG at the day of presentation from our ED.
Can't tell what it is. It's got a funny
Yeah,
accent.
there was some debate over it, but I think ultimately they just settled on atrial tachycardia, which you can see, as you heard earlier this week, in post-transplant patients. And then you also notice the voltage isn't particularly impressive. You're going to compare it to the prior.
Yeah, so this is the prior EKG, 1 year prior to presentation. You can see that it's normal sinus rhythm, normal voltage. The axis is normal as well. You can see here a right axis shift.
And decreased voltage, yeah.
Okay, so labs were significant for elevated creatinine of 1.98. Otherwise, liver enzymes were fine. Pro-BNP was elevated at 5,500, as well as troponin at 676. Prograph level, which is tacrolimus, was 7.9, which is therapeutic. Just to point out that 2 months prior to presentation, the patient had urine toxicology screen, and it was positive for cannabinoids and benzodiazepine. This is just to show you that his creatinine is always elevated. Maybe the baseline is around 1.9. It only normalized after BIVAD bridge transplant. And this is the tacrolimus level. It was always therapeutic. And at presentation, it was 7.5.
That's a therapeutic level, right? 7.5
Yeah, so it's
to 15.
5.
So, yeah.
Okay, well, what do you think?
So this is the timeline that I'm gonna walk you through this very quickly, just to have a sense of understanding of the case in general. So the diagnosis was done before 2019. EF was around 10%. Subcutaneous ICD was inserted in 2019, and LV thrombus was diagnosed in 2021 and treated medically. Then the patient underwent a bunch of serial investigations preparing for heart transplantation. In September 2022, he had his BIVAD implanted as bridge to transplant, and just 6 weeks later, heart transplantation was done, followed by a serial follow-up for 1 year, and then the patient lost the follow-up for around 1 year and then presented to our review with this main event that we're talking about. So I'm gonna start with the first TTE. This was done at the day of presentation.
Dr. Rabinowitz, can you walk us through the TTE?
So on the left, you have your personal lung, and you can see that the LV function is quite down, quite abnormal. Well, maybe a little thick, something to be a little thick or not. RV is hard to tell, just alveolar filtrate. So I'm not sure about that. A little bit of MR. On the right is your peristernal short axis view. So you can see top one is the level of the capillary, so mid ventricle. So the EF is considerably down, looks around moderately down. And now the lower one is basal, is at the level of the mitral valve. Here your apical views. Have the 4 and the 3, it looks like here, the 4 on the left. Very hard to see without contrast, the myocardial definition. The center image is a little clear, and again, the LV looks like it's significantly reduced. LV function, with the comment more details with the definity shots, and then mild MR. So this is obviously a little better in terms of quality. So probably moderately reduced LV function, probably in the low 30s. I don't know if I have to estimate. Hard to say anything about regionality here. Probably just pass on these images. Here is probably 30 to 35, something like that. And short axis with affinity, same, low 30s. At these levels, looks like it's pretty diffuse.
This is the last TTE that was done before presentation. It was done 1 year prior to presentation.
Yeah, it's just night and day. It's much, much better quality. LV function is much better. Pretty normal here in these shots. And peristernal lung in the left. And all these suggest that it looks like the baseline is pretty normal.
So our first question for today is, what is, in your opinion, the cause of LV ejection fraction drop? I just need you to scan this QR code. Take it directly to the.
Hi, everyone. You want to put the code back up just in case? Make sure the audience has a chance to scan it.
Medication during that year. Complicated. So he actually,
Maybe.
so he lost his insurance. His wife went his wife insurance, then his wife gets pregnant. They were homeless for a while, but then they were back. Also, what he did is he was cutting the pills in half, thinking that would last him longer, and he was not fully compliant with the medicine because they couldn't afford the medications. That's all.
Did he resume his alcohol consumption?
No. No.
Excellent.
He quit many months before. That's not the
Great.
he did.
So the rationale for some of these, right, if you can scroll up, Jad. So CAV, right, does he have some sort of ischemia due to graft vasculopathy? Could he have a drug-induced cardiomyopathy or alcohol-related cardiomyopathy? Could this be rejection? His Prograf level was therapeutic, though, but as Dr. Contreras mentioned, the meds were intermittent. Could this just be a tachycardia, arrhythmia-induced cardiomyopathy that's setting up that atrial tachycardia? Sometimes these patients can have infections that can cause myocarditis, like CMV. So a number of things on the differential here. Let's see what our audience thinks. Okay, a nice spread. Most people seem to think arrhythmia-induced is the most likely. That's great. That's great to see. So I think we were confused too with this case, and a good case to do some imaging. What does the panel think? What's the next best step to help figure this out?
With biopsy.
Okay. Let's go to the see what the audience thinks. Number 2. I think you might have to activate this one, am I wrong?
Oh, okay.
Yeah.
Show the QR code again?
It's nice.
So choices here, we could do coronary CT angiography to see if there's any ischemia through non-invasive testing. Go straight to a cardiac MRI to do myocardial characterization. We could do gene expression profiling, donor-derived DNA testing, which we'll talk about in a minute. That was something I had to learn a lot about for this presentation. We could go straight for biopsy, or we could do a left and right with a biopsy. Okay, let's see what the audience thought. A biopsy or left and right with a biopsy. Okay. Let's just talk a little bit about some of these other choices in our repertoire here. Do you want to go back to the slides here? So one thing sometimes we do as we're surveilling patients with transplant for rejection is the AlloMap and AlloSure tests. Could you tell us a little bit about how you use these?
So we use this mostly to follow post-transplant, and basically AlloMap is analyzing 11 genes that get activated when you get a rejection. So you see you have activation of genes that would be genes that would be activated. You are having acute rejection, like inflammation genes. So the score varies as you have post-transplant. So initially we have a different score system, but they give you the score of the activation of the genes. Usually less than 30, which sometimes 20 something, depending on the time of the transplant. We usually follow patients with that after usually 45 days post-transplant, because that can get affected by the high levels of steroids, because obviously if I give people high steroid dose, obviously those genes are being suppressed. We have to do it that way. And the other shot is basically cell-free DNA. You compare the cell-free DNA from the donor and the recipient, and obviously we want a cell-free DNA less than 0.15. Some people say less than 2 is more suggested on no rejection. But you think about it, this test can be done early because it's not affected by steroids, but it can be affected by other things. For example, you get a heart and a kidney, your cell-free DNA can vary because you can have cell-free DNA coming from the kidney or the liver. So in multi-organ transplant, we don't really have a lot of data yet to understand that. But in post-transplant patients, if the patient hasn't had any rejection in the first 4 to 8 weeks, we probably will follow them monthly or every couple of weeks with the blood work. And if the test came back positive, then it's when we do the biopsy. That was created to decrease the amount of biopsies. So we usually used to do a biopsy every week for 4 weeks, then every 2 weeks for 2 months, and then every month up to 1 year. And then we do it again. Used to do it every year if we want, or depending on the patient. But now if the patient doesn't have any rejection in the 4 to 6 weeks, we can follow them with the cell-free DNA, and then we can just decide to do a biopsy if the patient has symptoms or the cell-free DNA come back positive. But there are like a lot of like false positives that you can have. Cell-free DNA.
Terrific. Okay. And I think we have the initial. So this is, can you explain this?
So you see, he was transplanted, and then the AlloMap is the template. So it went up a little bit, and sometimes we re-biopsy him when he goes up because we're worried, and then that gives us a chance to see where he goes up and down, and then where he stays usually. And you look at the cell-free DNA that the allo showed, it was negative. There was a little spike there, but we probably biopsy at that point, and there was negative, and then you see how as the transplant goes, you become negative. So usually after 1 year post-transplant, I mean, depends how people do it. We usually do it every 3 months, but we don't see the patient as frequently, and sometimes every 6 months. But after 2 years post-transplant, there's really no data about the validity of this test for patients. We're actually looking at data for that, and that test can be affected. You have persistently elevated cell-free DNA. Some data shows that you can have more chance to have a CAB, chronic CAB. Because remember, CAB is a chronic rejection, low level of chronic rejection that you are having in the arteries. But there is not a lot of data and correlation for this.
Terrific. Okay.
And you see in April, because that spike, we actually biopsy him and it was negative.
So at least before this presentation, these labs were not particularly concerning that he's got something doing yet. Okay. And you mentioned CAV, so let's talk about the, right. Do you want to mention this here, Jen?
Yeah. So This was a prospective study that was done, actually published 4 months ago. It's about testing CCTA and cardiac allograft vasculopathy compared to invasive coronary angiography plus IVUS. So they found that CCTA is pretty accurate for surveillance of CAV in patients with heart transplantation when it's coupled with plaque analysis. So it has an accuracy of 89% with a sensitivity of 79 and a specificity of 98%. So you can clearly see here several degrees of stenosis in the proximal LAD, mid and distal LAD. Also, it's obvious on the invasive coronary angiography. And that's what you see on IVUS. Even mild plaque can be obvious on IVUS, for example, over here, and it's very obvious also on CCTA.
It's great. Go back one slide. So these recent studies have shown that CCTA really is a nice tool for monitoring for CAV in these post-transplant patients. And just go back one more slide. You can see, like you said, Jet, that there's sort of this diffuse, ragged tapering of the vessel. And you can see that both on the CCTA on the left and on the cath on the right. One thing that's nice about the CCTA, and of course I'm biased here, is that the cath is really a luminogram. You can't really see the walls, whereas on the CT you can see what's going on. So we've got a few different non-invasive possibilities here. Do a CCTA, we could do some lab testing, but the panel, you said we should probably just jump to a biopsy. Is there a reason why we jump to that most invasive test first?
Because early post-transplant acute cellular rejection is probably more frequently. I mean, CAV is something more like chronic post-transplant. The technique that haven't validated the IVUS because you can see the intimal growth, and because it's more like a concentric pattern and it's like a chronic rejection, you can actually see that intimal growth and having the most validated, and you can classify patients depending on how they grow. It's CAV 1, 2, 3. So yeah, but more frequently, early post-transplant would be cellular rejection.
Okay. And I bet also if these non-invasive tests were negative, you'd probably still maybe not trust them 100% and still need to get some tissue, I guess. Okay, so let's go. So you went for left and right, right?
Yeah, so left and right heart cath were done with biopsy at the day of presentation. So this is the left heart cath. You can clearly see the circ over here with OM1, LAD and diagonal, all looks normal. This is the RCA and an LV angiogram over here, just to see the systolic function.
He had tachycardia at that time.
Yep.
It persisted.
And so no evidence of CAV on the cath, correct? Okay.
IVUS was not done, so. These are the pressures from our right and left heart cath, also at the same day of presentation. So the cardiac index was very low at 2. All the pressures were elevated. Wedge pressure was 25. RA pressure was also 25. PVR 1.5, which is normal. SVR at the upper limit of normal. QPQS was 1, no shunt. LVEDP was also elevated at 25.
Dr. Contreras, what are you focused on when you see these numbers?
I mean, he's in heart failure. He did have some gallop, and he did have some edema. I think probably the important in the physical exam. But he was tachycardic. He was in basically full-blown heart failure. And surprisingly, almost going into shock. That's how he presented to the hospital. And that's how acute rejection presents. It comes to tachycardia, sometimes AFib, sometimes even acute, complete full-blown shock. I'm surprised he was probably going into, so he was very sick, and that's the hemodynamics. His RA pressure and the PA and the wedge pressure is the same, so his RV was really terrible.
These are the serial right heart cath that was done for our patient even before transplantation. So you can clearly see the cardiac index was very low at 1.7, increased a little bit after IAPP. And after transplantation, it normalized until our day of presentation. It went down to 2. And then all the follow-ups showed elevated pressures with low cardiac index.
And, he was from well-renowned and ICU, and he was like super sick in the ICU at that time. He was super sick in the ICU in inotropes for a while.
Oh, okay, yeah. So let's go back to our admission. So the biopsy result came out, it came back to be positive with acute cell rejection of moderate severity, grade 2R, with no histologic evidence of antibody-mediated rejection.
We're fortunate to have Dr. Beasley join us. Would you walk us through these results? I know we have some slides as well.
Right, so this is fun for me because I don't really get to see what's happening on the other side of the biopsy very often. Usually we're just frantically trying to get the biopsies out and I'm communicating with Joe and Erica about what's going on. But just for background, I'm sure you all know this very well, but this is our grading system for acute cellular rejection. So, the vast majority of ones we get are 0, so we have no lymphocytic inflammation. And basically for all of the grades, we're looking for a certain amount of lymphocytic infiltration or the presence of myocyte damage to a significant degree. So 1R mild, this is perivascular interstitial lymphocytic infiltrates, and you're allowed up to 1 focus of myocyte damage. 2 is usually a little bit more diffuse, but critically you have 2 or more foci of myocyte damage. And then 3, which we rarely see, is just really extensive inflammation, multifocal areas of myocyte damage, and sometimes you can see some vasculitis as well. So this gentleman, prior to the time of the presentation, we're talking about all of his biopsies, and he had 4 or 5, as I recall, were all grade 0. So I'm just showing this one for kind of a baseline. By criteria, you need a minimum of 3 pieces of tissue. Ideally, you usually have more than that. This one, as you can see, has 4. And you can see it's very pink. You may remember from your basic pathology, pink is good, blue is bad. So we have all pink here. We have no lymphocytic inflammation. So these are very clean biopsies. But then we jump to the October 10th biopsy, and this is a low power. So again, blue is bad. So you can start seeing here that we've got multiple areas of blue suddenly appearing all throughout this biopsy. This is not really what you'd expect with a 3, which is usually inflammation kind of all over the place, but this is at least a high 1R or a 2. So we need to go and look for myocyte damage, and that can be a little tricky. So ideally what you're looking for here, you want to see the lymphocytes directly damaging the myocytes, and that's where our trichrome stain that we usually get with these comes in handy, because you can actually see whether the lymphocytes are on top of the myocytes, and rather than in any fibrosepta that are there. But what you're ideally looking for is something surrounding the myocyte. It should be sort of scalloping it in. So this had obviously a lot of lymphocytic inflammation and at least 2 foci of myocyte damage. So you can see kind of here, you've got 1 sort of scalloping here as well. So definitely a 2R in this case. This is some fibrosis with some lymphocytic inflammation as well. So it's always kind of hard to tell if that's some prior damage or not, but we have definitely a 2R in this situation. And then I didn't realize antibody-mediated rejection was an issue in this case. This one did have a 1R, as we call it, with the C4D. So the C4D, in order for it to be positive, has to have circumferential endothelial staining that should be strong and intense in over 50% of the capillaries present. This one has what's called a 1R, so that means it's usually faint or focal, but certainly in fewer than 50% of the vessels. So that's what we had in this one.
Thank you so much. Okay. And then Dr. Contreras, you said,
This is great
Yeah,
here because we do the biopsy, and in this case, the suspicion of rejection is so high that we treat this patient immediately with high dose steroids. You don't wait for the biopsy result, because we already, with every data that we have, we are actually expecting this to be, So we tortured Dr. Beasley and so then in his case, he had a lot of risk factors. He presented almost in shock. So we are worried about having both cellular and humoral rejection. So we send these DSAs that basically donor-specific antibodies, and you look at the antibodies in this place. He has tons of antibodies forming against the donor-specific antibodies, and then you go to the next page. This is class 1 antibodies, and this class 2 antibodies you look at some of the antibodies are in the 20,000 range. You go and you calculate the CPRA doesn't, it's 87%. You look at the next slide, you have her baseline antibodies at 0%. So he didn't have any antibodies prior to transplant. And when he comes now, he has tons of donor-specific antibodies. So that is telling you that he also has a humoral rejection. These tests take time to come back. So we usually, really with cellular rejection, we have enough data to treat him. We like, you get steroids, IVIG, rituximab. But now, when we get this back and he also have antibody forming, even though the histology wasn't consistent, we are worried that these antibodies are going to eventually cause trouble. So we actually treat him with Plex, with plasmapheresis, to be able to get rid of some of the antibodies.
Okay, fantastic. And this is, I think we had mentioned this before, but I guess the AlloSure level of the admission was still not particularly impressive.
Yeah, pretty elevated, but yeah, well, you see how he go back up persistently.
Okay, so you mentioned it already a little bit, but I think this is the everything that was done on this mission. Did you
So
anything else to mention?
Yeah, we're doing it aggressively with both. So we do with cellular and humoral. So you get the prednisone, you start immediately that day. As soon as you get the biopsy, we start the prednisone because Simon overly had those cells have IVIG, and we actually get up to the program high level. You have to add antibiotic prophylaxis because obviously you're gonna autoimmune spread especially, and eventually you start on GDMT for heart failure because you obviously have heart failure.
So even before you get the biopsy or the PRAs back, you're treating for both cellular and humoral.
No, I would say
rejection.
we will start with the steroids, IV high dose steroids immediately, and then over the next day we will get more answers. So we decide for the next treatment. So we start IVIG and Thymo the next day.
And he did go back one, and I think he did pretty well, right? I think the
I mean, it was very safe, but yeah, it
he was able to
it
go.
was in control for a few in the ICU, and then you had to repeat the biopsy and see your treatment is being effective.
So the biopsy was repeated a week later on these therapies. Dr. Beasley, can you tell us what we see here?
So this one, so on the low power, you can see here on the right, this looks markedly less blue than the one before it. So we just have just a few lymphocytes hanging around, still remaining in this biopsy. So this would be a nice example of a 1R. So a nice response for him.
Is there any other markers when you do the C4D? Sometimes we do C33.
We don't have CD3, so we have C4D. We don't routinely do the CD68. That's an extremely non-specific antibody, and it's also very difficult to interpret. If we have a positive C4D, I'll do a CD68 to look for circulating macrophages, but by itself, it's hard to interpret. Not a very good antibody, so that's why we don't do that just routinely on all the biopsies.
How you treat the antibodies, plasmapheresis?
We do plasmapheresis to remove antibodies, the antibodies that are circulating.
But they don't come back. I mean, because
They will come back sometimes, but we're hoping that as we immune suppress and get rid of the antibodies, you want to get rid of the antibodies so you don't create more damage to the heart. You need to get rid of the antibody with plasmapheresis. But you have to repeat it. Now it's in photophoresis, chronically.
You're attacking both production and circulating. How long do what's the half-life of the antibodies, any sense? They're long-lived?
No, they actually they have a long life, but they can come back. But you're hoping
No.
with the plasmapheresis, you're eliminating, and you continue to follow him up, and we continue to follow him up, and the antibodies came back up. So we actually start photophoresis chronically to try to suppress that antibody production.
So he goes home on GDMT, symptomatically doing okay, but this is the echo that comes back 2 months later. So,
Not great. doesn't look that much different from the prior one, I would say. It's like it's probably dilated, probably definitely moderately reduced. Looks like.
it's worse.
Yeah, and now the fin actually maybe even looks a little worse. This probably looks like it's moderate severely or severely reduced. It looks pretty diffuse.
So despite giving some really good therapies in the hospital, the heart is still really struggling here. So the patient went for another biopsy at this time. And what do we see this time, Dr. Beasley?
Right, so he's, from a biopsy standpoint, he's looked good since, so here we have, the follow-up biopsies at 0 R. I include, so there's no lymphocytic inflammation here. I included this picture to show, so in the report, you'll often notice we'll comment if a biopsy site is present or not. So the top here is the biopsy site, so you can see some fibrin, a little bit of granulation tissue at the top. Sometimes that can be very exuberant and actually kind of scary looking. But that's all that is going on in the top, but there's no rejection going on here.
You said biopsy site, prior biopsy site?
Prior biopsy
So we're
site.
biopsying a biopsy.
Yeah.
Okay, so Dr. Contreras, we've got a negative biopsy times 2. Heart seems to be getting a little bit worse despite best therapies. How are you thinking about this case at this time?
So we worry because obviously his heart is getting worse. But also we're treating the rejection. He still have antibodies circulating, and that we're already treating with the plasmapheresis. So we're concerned about what's going on. So we actually, that's why we decided to do the MRI to have a more picture of
It's okay.
why is the heart actually getting worse. Also, his kidney function is also bad, so we don't really can optimize his medical therapy because obviously his kidney went up to 4. So we couldn't really use a lot of the medical therapy that we use. So we're concerned like why is the heart still so.
Okay, makes sense. So negative biopsy, bad ejection fraction. What's the next best test? So should we go back and do coronary angiography to see if we missed something? Should we go to a cardiac MRI for tissue characterization? Should we up the meds? Should we do some more testing to see? Do our allogeneic alloMap testing? Should we repeat a biopsy? Looks like everyone wants to go for the MRI. So, Dr. Kukar, you're up.
It is an imaging comment. Something.
Just slides are imaging, I think, you know, it's multimodality.
It's a bias.
Yeah, exactly. So you have some nice stunning images on the MRI. So similar to what Dr. Rubinowitz commented on with the echo, it looks like the EF is kind of severely reduced. On the left, obviously, you have a 4-chamber, in the middle, L3, and on the right, A2. And so you can see that the LV looks probably slightly dilated, and again, kind of severely reduced. Next slide. So again, now you have a short axis image. Just kind of, again, confirming that the LV systolic function is severely down. So here you have the SSFP images, which are kind of just the baseline diastolic images on the right from the cine shots, just so you have a good direct comparison of the wall versus the delayed enhancement on the left. And as Dr. Kassem probably kind of astutely pointed out to me, if you're looking at the enhancement, this is actually one of these cases where you might think there's just pericardial enhancement as you kind of look at this white linear line for anyone who doesn't read kind of MRI in the room. But if you compare it to the wall thickness on the SSFP shots, you can see that it definitely appears much thinner on the delayed enhancement. So this likely represents subepicardial diffuse enhancement. It probably also extends into the RV, which is always slightly more difficult to evaluate to a thin wall. But certainly I would say there's diffuse subepicardial enhancement, possible pericardial involvement. So I think the differential in this case, just based on the enhancement pattern at this point, would be myopericarditis versus rejection, which I'm certainly not an expert on, but in this clinical situation would be a possibility. Again, as you go to the right, you see the SSFP and diastolic shots, short axis, and you again see that the wall thickness appears less on the enhancement images, suggesting subepicardial enhancement.
Can you go back one more before this? This one. This picture is so impressive on the left.
Yeah.
You can just clearly see that subepicarditis.
Yeah, it's pretty impressive. We were talking about this, just saying, if we had this patient without transplant, I would say this is very bad myopericarditis. but it's quite extensive and it's circumferential.
That'd be.
Yeah.
Very impressive.
So again, just multiple ways of looking at it, and I think on this 4-chamber shot, you can kind of actually really appreciate, as Dr. Larakis was alluding to, that it does look like there's RV involvement with this enhancement as well. On the top left with the 4-chamber, and again, just really emphasizing in the 4-chamber and the 2-chamber, just the diffuse nature of this epicardial enhancement. Okay, so here we have the T1 map and the extracellular volume, which are essentially looking at intrinsic tissue property of the myocardium, and this can be elevated in cases of fibrosis and extracellular volume as well. So there are multiple different reasons this can be elevated, but elevation in T1 and ECV implies another process going on with essentially fibrosis or inflammation changes that such as that. So you want to go to the next slide? So the T1 in this case was quite high at 1165. I know in this scanner in Mount Sinai East, the norm is considered 1109. ECV is markedly elevated. That's the extracellular volume. Again, we're looking for differences. Typically, we'd have myocardial, a certain percentage of extracellular volume with the myocardial cells. And so normal would be considered under 30%. And so this implies fibrosis or inflammation. So high extracellular volume, again, implies an inflammatory kind of process. T2 is remarkably elevated at 60 milliseconds. And again, the normal on this scanner is 52. On a 1.5 T, which does matter what scanner you're kind of using it on, this T2 can change. Typically anything above 55 is considered abnormal. And I think we can go to the next slide. Do you want to talk about this?
This is a very interesting systematic review that tested the performance of MRI, especially the parameters that we talked about already. So they found that the LGE actually had the lowest area under the curve at 0.56, with a sensitivity and specificity of 50 and 60% respectively. So they said that LGE is actually not useful tool for the detection of acute cardiac rejection. And why is that? Because we have false positives and false negatives. So sometimes we can see LGE in the absence of graft rejection, for example, in older donor age, in longer ischemia time, and in more biopsy procedures. And of course, also we can miss some scar because it's too small to be detected by the LGE. And now it's very important to point out that the extent of LGE is an independent predictor for MACE following cardiac transplantation. Another parameter that they looked at is the T2 mapping. So they found that the area under the curve was the highest at 0.92, with a sensitivity and specificity of around 87%. So the optimal T2 threshold that they found out to be to best distinguish patients with rejection was 54.75 milliseconds, which is nearly identical to 55 milliseconds. The upper limit is considered of normal T2. Now, this is just to show you that all parameters, including T2, T1, and ECV, will increase after transplantation and also will increase furthermore with active rejection. In another study, they tested the global ECV, and they found out that ECV was not elevated in recipients with a history of rejection, but was only elevated in patients with active rejection. So if you look at these numbers, you can see that it's kind of identical, except for the patients with active rejection. So we can say that in patients with significant history of rejection, ECV is the most important parameter for diagnosing active rejection.
Okay, so just to summarize, Dr. Cougar, it sounds like we've got a significant amount of edema enhancement consistent with active inflammation, which in the clinical setting sounds most likely to be rejection. But the biopsies that Dr. Beasley showed, clearly there isn't very much infiltrate. How do you put this together, Dr. Beasley? Biopsy, of course, is the gold standard. Is it that these studies were a couple weeks apart? Is it that we could sometimes miss the patchy inflammation? What do you think?
Yeah, you had asked me that before and I couldn't really find any like hard data on how often there is a disconnect between the biopsy and the clinical findings. But, you know, it's not horribly uncommon that one of you all will email me with this horrible sounding clinical history and I'm like, oh my God, this is gonna be a 2R for sure, and there's nothing there. So I don't know how to speak to that. I would think that we're probably, I find it hard to believe we're missing a 2R with any sampling error type issues. I would think a focal 1R, yeah, maybe, you know, because that's kind of gonna be more akin to like when you guys are looking for sarcoid and we just don't happen to have a granuloma in what you've sampled. So, you know, maybe a 1R, but as far as something more significant than that, I would like to think there would be, you know, a low significance of sampling error in that situation.
Another maybe, you know, I mean, these findings on the MRI maybe like when she had acute rejection, when the biopsy was positive, maybe take time for this to go away on the MRI, you know. So maybe
Yeah, so the 2-week delay could be,
maybe
could be.
there's a delay for the MRI to normalize compared to the biopsy, you know. That's a thought, you know.
Yeah, absolutely. And then one of the other things we were thinking was, is it possible that because we had that subepicardial area of enhancement, is it possible when they do the biopsy, it's just too far away based on what they typically sample? Have you seen that in these rejection cases?
Like if the inflammation is
If the
just
inflammation
localized to
is,
the
like,
epicardium,
localized to the
but
epicardial
biopsy in the
area.
endocardium.
Yeah, because you're technically not supposed to get epicardium.
We don't wanna cause a
We're
problem.
always supposed to make a comment when you get fat in the biopsy. Yeah, so certainly depending on the location that
I don't know, you would go into the right septum, so the right ventricle to the septum, yeah, you don't wanna get part of the
You
body.
almost have to do what the EP people do. in their
Exactly.
Approach, which is a little bit dicey, especially if you've had prior surgery.
So we had done like in COVID, for example, for COVID myocarditis, a lot of the myocardial biopsies were negative, and we did a gated epicardial biopsy and they were positive for myocarditis. So that's what it is sometimes hard to be able to do it. But obviously in this process, it's such a systemic process and he's presenting with heart failure and shock, respectively the 2R rejection is gonna show up in the biopsy and it did show up.
When we've all rotated with Dr. Sweeney, he goes in, he takes a number of chunks of tissue.
Yeah.
If it was a 2R, are all of those biopsies positive, or even then can it be patchy?
it still can be patchy.
So it's possible that we could miss something if it's just.
It's possible, I would find it hard to believe you wouldn't see anything. So I think, you could potentially have something that's called a 1R and maybe due to sampling, it's perhaps a 2. It's hard to believe you wouldn't see anything at all.
Bear in mind, you saw a biopsy. They're bringing the bioptome where they think it's safe. And that's the major issue. Don't kill the patient while you're trying to get tissue. Then try and get good tissue, but that's the order.
Some of the studies Jad pointed out, a lot of the parameters can actually stay up, like the T2 and the T1 can actually stay elevated, but the ECV was markedly elevated, which suggests more of acute rejection.
If there are functional things, this guy he's not drinking, doesn't have any toxins, and the tachycardia is behind him. But the functional things, tachycardia-induced myopathies and stuff, they probably don't show up as anything, anywhere, in any testing we do, except it's functionally crummy. Right. You don't have any energetics. I don't know if there's anything ultra-structural it's worth looking at, but I have no idea.
We do molecular microscope in some patients, but we're just learning, and you can see in the molecular microscope you have acute rejection and you have activation of genes in the molecular microscope, but we're just learning how to use that technology.
So Dr. Contreras, how did you put all this together in terms of managing the patient over the winter?
So I think you probably have a bad case of acute cellular and humoral rejection. We treat obviously the acuity, but I think the damage that the heart is having obviously is there. He's probably gonna have scar tissue and eventually gonna have more scar. He had persistent elevated humoral antibodies, and despite all the treatment, so we actually put him in photophoresis, that is the latest thing, and the fact that he's not getting better is a very bad prognosis. He also has kidney failure too, so it's also making things difficult because even with GDMT, it's very limited what can we get. So I think he's gonna need a pre-transplantation and probably had a kidney. But really, we had to. He's very obese now, so we have him on Ozempic, and he needs to prove compliance. He needs to make sure that he has insurance. He just had a baby. He's a young guy, so usually young people also are tough because they want to live their life and they really don't want to be sick. This guy is in his studies. So we're following him very closely, and he's getting for the 40s to try to keep everything down. But it has not gotten better. So right now, his EF is still 20 to 25%.
Let's show the most recent MRI we had one a couple of days ago.
I have a question. What about why this guy has so many antibodies? Because you check the patient before to see if it's a good match, is that right?
Yeah, they're coming down. I think it's the
No, I'm saying that you check the patient before you do the transplant. You check for antibodies to make sure it's a good match donor recipient, is that right?
I didn't have any antibodies prior to with the PRA. So the PRA gives you a chance of how many antibodies we have against the pool of patients, and he has 0. So he doesn't have any puriform antibodies. So these antibodies are donor specific. So it happened because acute rejection the organ. They're coming down. But when you have both humoral and cellular rejection, and my guess is probably what happening for some time, and probably the damage was already done, it takes time to keep them immunosuppressed. But he's better from that regard. But I think the damage in the heart.
The cells don't look that awful, that Dr. usually shows, but what you're describing is they don't work well. We're missing something.
So again, on the left, you've got the cine images. You have a beautiful appendage if anyone is interested. It's pretty clean. In the middle, you have a nice 3-chamber shot. The aorta appears a little dilated to me. On the right, a nice 4-chamber. So again, this EF is just getting worse. The LV looks like it's dilating, diffusely, severely hypokinetic. Next slide. Again, you have these short axis images where, it's interesting because the heart, none of it's thick. It certainly doesn't look like there's anything thinned or scarred, which is another feature we'd obviously want to comment on. But severely reduced, diffusely hypokinetic. Now again, we have the gadolinium enhancement where you're again appreciating this one a little bit actually more clearly that you have a thin sliver of what looks like healthy myocardium outside the layer of enhancement, which suggests again diffuse subepicardial enhancement as we saw in the last shot. Now, unfortunately, on this one, they could not do T2 mapping, and T2 mapping. Obviously, now we're able to do like quantitative parameter to assess edema. T2 is typically looking at transverse relaxation time. So, while we might be able to visualize that on some of the T2 weighted images, however, we still are able to discern that the T1 is elevated, the native T1. The ECV is markedly elevated. That's calculated using the hematocrit on the same day, but otherwise we're able to calculate that with T1 pre and post contrast. So in this case, I would say that all of these parameters remain significantly elevated many months later. And one of the things we had been speaking about was whether there was myocarditis in this differential, but for really none of these parameters to move in any significant direction many months later. I would say in this clinical situation would be more consistent with chronic rejection.
Terrific. And can you show the most recent biopsy as well? Would have been a couple slides before.
Yes, so this one, this is the March 25th. So again, it's negative. So the myocardial tissue looks pretty good. The infiltrate that you're seeing on the right, that's in the endocardium. So that's a small quilty lesion, just to illustrate that, since that's another thing that we sometimes run across in these biopsies.
Can you explain what that is? I'm not sure we know what that is.
So basically, a quilty lesion, it's an endocardial collection of lymphocytes, and you'd think that would mean something. It's been somewhat linked to, pending acute rejection and things like that, but it's always amazed me that there's not a stronger link with something in regard to these. But from my standpoint, the main thing that can happen, now this one's small, so it's not much of an issue, but they can be quite large and actually will appear to extend into the underlying myocardium. So it can be confused with a component of rejection. So that's one reason the guidelines for managing these biopsies, you should get multiple levels. So if you see some infiltrate in the myocardium just beneath the endocardium, you'll see it connect back up, and that favors the quilty lesion. The quilty lesion does have a B cell component to it, whereas the rejection should just be T. So immunostains can help with that. If you see a B cell component in the infiltrate, then you know that it's quilty as opposed to rejection if you have a case where it's really kind of tough to tell. But as far as the myocardium here, you've got nothing going on. It's very clean.
And so even though we don't see any lymphocytic infiltrate, the ejection fraction is down. Is there any other information we can glean from this in terms of why the heart isn't pumping very well? Any myocardial damage or fibrosis?
No, I mean, this really looks, pretty good. I mean, there's a little bit of hypertrophy in the picture on the right. You can see you've got a few boxcar nuclei there, but it really doesn't have much in the way of fibrosis at all. I mean, it really looks, pretty decent, honestly.
Okay. Got one more pull everywhere question to round this out
No
here.
virus, no virus, no nothing.
So at this point, what should we do next? And this brings us that MRI was from this week. Should we continue to immunosuppress? Dr. Contreras mentioned maybe going for a retransplantation. Should we get some more data?
I was gonna say it wasn't on your list, but I think it's important.
Right.
Say pray? Yeah.
Right, yeah.
Okay, what do we get, Jeff? Okay. Some of these are not mutually exclusive. You could go up on the meds and work up for a retransplantation. What's his candidacy going to be given everything he's been through?
Yeah. So many things like compliance, which is very, very compliant, serial assessments, and now he did have some antibody. So photophoresis. We don't have a lot of data, but it's like the last resource. To be able to keep so he's having chronic rejection. Whatever happened to the heart becomes stiff. It's not working that well, and he's gonna need to lose weight, and eventually consider for heart and kidney transplant.
How long you have to wait between?
I mean, he's stable-ish right now, so I mean, you will want to listen as soon as you can, but you have to get retransplantation. You have to prove that he's compliant. You have to prove that you're gonna keep the insurance, and hopefully try to get an organ for him to be tough because he has already antibodies. So you're gonna have to cross-match the organ, usually for kidney anyway. His kidney is a little bit better, so we're hoping that maybe get better. But yeah, as soon as he can lose the weight, we need to. But this guy, I mean, sudden cardiac death is the most likely cause of death in this gentleman. We actually want to bring him back now for an ICD, just because there's not a lot of data post-transplant. Because sometimes even acute rejection can happen with normal ejection fraction, and even if they have CAV, they won't have that. But his biggest risk right now is sudden cardiac death.
And I assume you're going for transvenous ICD as opposed to subcutaneous, to deal with the chest and stuff.
Any questions from the panel or from our other centers joining us, West Morningside?
How fast you expect an acute rejection, when you treat it to see recovery, like if
Fast.
somebody will respond
The way we treat him, you respect the biopsy by 4 weeks should be completely.
up to normal.
But if we have been let's say he stopped the medicine and it's an acute rejection, you treat him acutely and in 4 weeks his EF should get better, his biopsy should get cleared, and he probably should get better. And especially just cellular rejection.
I think it's because because he was lost to follow-up, that we just didn't find it early enough, and then.
I think by the time he came with symptoms, he probably was having symptoms for a while, and he just came in because he couldn't take it anymore. I mean, he came pre-shock when he came to us, when stage A or B was shocked. But then, we probably were having this for a while.
Yeah, we
That's my
came
guess.
across some papers about them using CMR for evaluation versus biopsy, 4 weeks, 8 weeks, 12 weeks. But are we as a possibility instead of biopsy? Is that something they?
That's a good thing because already the invasive procedure is hard to get the patient to be the way, and we are doing more imaging now. For example, for follow-up for CAV, we do CT, MRI, CT PET, because we actually want to like do a CAT. Usually you do a CAT at 6 weeks and a year to look at CAB, and then that gives you a prognosis of what the patient is. If it's a patient that is older or he get an older donor or he has some CAB in that year post-transplant, you may want to change the immunosuppression to different drugs like everolimus, sirolimus that have less or like it decrease CAB chronically, but and you will repeat the CAT. But now we don't want to repeat the CAT all the time, so with the nuclear medicine CT bed, we can actually have a pretty good data. And because you do a CAT, you really want to have eyeballs because you want to really see the changes. And you have to treat the patient aggressively, like cholesterol, aggressive with cholesterol, diabetes, and unfortunately, like the program, cyclosporin, all these drugs that we use, they can't get the patient to have diabetes, chronic kidney disease, hypercholesterolemia. So we have to treat these patients very aggressively.
Is the antibodies he has now, assuming he is now compliant because he has insurance and stuff like that, does that predict antibodies to a second transplant or not really? I'm afraid it does. That's what
Unfortunately, he has preconceived antibodies, so he's gonna react to other organs. So when we actually get a next organ, we have to cross-match him to make sure that he has.
But if you cross-match and he's negative, is he at a higher likelihood, assuming immunosuppression is good, yet again?
Anybody with the PRA more than 10%, we have a high risk of rejection. And usually, retransplantation had the worst prognosis patients.
The question in the back.
I wanted to ask a question for Dr. Coker. Regarding the MRI in these patients, we recently have been doing a lot of follow-up for heart transplant, assessing for possible rejection, even asymptomatic patients. As we saw, like we normally want to check, especially the parametric imaging, like T1 and T2. Some of these patients have like sinus tachycardia, and some of them have like pacemakers after the heart transplant. In those patients with devices or like tachycardia, sometimes I find difficult to trust the values that I'm getting like in the parametric imaging, which like a small variation can be like significant or not significant. Something that you encounter also, or do you have any advice for how to?
That's very interesting. I understand. So basically, when you're doing T1, T2, you're usually, as Jad saw, if you saw on the slide, they're taking a sample at the septum. So that can be difficult if there's a lot of motion from the tachycardia or there's paradoxical septal motion. Certainly that can make it challenging. We did come across some studies where they're also typically using global T2 and global T1 versus this kind of peak segmental that we're looking for. So I think as the technology improves and we're not so dependent on, I've had this experience even with T2 star where you're looking for iron overload and you take one sample and it might be concerning in the other, and what do you do with that? So it's definitely a known kind of challenge, and I think the fact that you're on the other side where you understand the clinical implications means you'll just realize that your values mean something and you won't just take it blindly. I would just say that taking larger samples and trying to replicate it would be the best advice in those situations. We typically obviously don't beta block for those, but it's funny, it's slow and sometimes they did on rarer occasions, but I would just say cognizance and routine follow-up and possibly using some of the more advanced technologies to get a global map versus just a peak segmental would be the best.
Yeah, and this is one of the reasons we don't do it all the time, because they have tachycardia, they have vagal denervation, so they're always going to be tachycardic. So it's hard, and they don't respond to beta blocker that well either.
As I said, they don't respond.
Yeah. So I think some people later on post transplant, but acutely won't respond to beta blocker therapy. So that's tough with MRI.
But you raise a very good point. I mean, it's kind of like taking an LVOT and an echo, and it can mess up all your dimensions. So even when you're calculating the ECV, it's dependent on your T1 value. So if your T1 value is not reliable, how are you calculating the ECV? So I think like anything else, nothing is perfect, and it comes with certain limitations.
Has anybody looked at this tachycardia? These transplant patients, if it causes cardiomyopathy, like this causes continuous tachycardia.
No, the tachycardia is normal because you have vagal bigger than your patient, so when you get the new heart, you don't have that, so you are persistently tachycardic.
That's what I'm saying, but they have looked if that tachycardia is causing cardiomyopathy.
That's, no. They usually, with time, come down to like the 90s, 100s, usually.
Thank you so much to the panel. Thank you to Jack.